Dr. Cairo, it's a great honor to finally meet you.
Such a pleasure to be here. Thank you so much for inviting me.
Thank you. Dr. Cairo is a medical oncologist at Texas Oncology here in Houston, and she has a special clinical and research interest in breast oncology. And I know you did some training at MD Anderson. We didn't cross paths at that time,
but this
is amazing that you also trained at the same institution. It's so nice to have you here, and I'm so happy to have you here. We're gonna dig deep into some data that was recently presented. Thank you.
My
Thank
pleasure.
you for joining us. We're gonna talk about the hormone positive metastatic landscape, and mainly the area where everybody gets stuck on. That's the endocrine refractory setting, when the cancer does not respond to hormones. Very frustrating thing for a physician and devastating to our patients. But thankfully, it is changing. We're going away from chemotherapies and moving into the era of antibody-drug conjugates, which is such an exciting era. And to that, trastuzumab, deruxtecan, and TDXd play a huge role. And two pivotal studies has been presented in the few not distant years, the DESTINYBreast-04 and the DESTINYBreast-06. I want you to give us an overview about those two studies and their findings.
Certainly. I mean, prior to DESTINYBreast-04, and it wasn't that long ago, but it was such a major frame shift, it was hard to remember the thought process from prior to DB04, where we looked at HER2 as binary. It was positive or it was negative. You always had this sneaking suspicion and inkling that, probably some of your 2 pluses or those 1 pluses who were FISH positive, maybe they were going to be responding to HER2-directed therapy, but we didn't have any evidence of this until DB04. So DB04 randomized in a 2-to-1 fashion patients who had progressed on endocrine therapy and also in a line of chemotherapy, and randomized them to either T-DXd or treatment of physician's choice. And the list of the chemos was pretty exhaustive. And then showed us the results. And these were all patients who were HER2 low. So these were patients who we had previously would not have considered for HER2 directed therapy. But using an antibody-drug conjugate with its bystander effect gave us possibly a greater opportunity to be able to sort of enrich the population who was going to benefit from ADCs and to capture that population before they had to move on to really the scary and frightening and side effect prone hair loss, chemotherapy. And so that's where we met DB04, which represented a clinically significant progression-free survival over chemotherapy.
I mean, I echo you. It was fantastic to see. Like the antibody-drug conjugates, the way I look at them is like the silver bullet, right?
Yeah.
Yes, they have a payload that is a chemotherapy, but here you're trying to spare healthy cells.
Yeah.
And it's fantastic to see we came a long way from giving chemotherapy to the whole body to just targeting them. But that's the DB04. What about the DB06? What did it add to the DB04, and how does it differ from that?
Yeah, so what the DB06 added was it added not only the HER2 low, which is defined as the 1 plus and 2 plus, the FISH negative, but it also added that ultra low category, HER2 zero. I mean, just really sort of mind blowing that you could have something that was labeled as HER2 zero, but could have just a speck of HER2 expression on the cell surface, and that could potentially be enough to see activity with trastuzumab deruxtecan versus treatment of physician's choice. So this was randomized 1-to-1, T-DXd versus treatment of physician's choice, and the chemotherapy arms were a little bit smaller. It was just the taxanes and capecitabine. Which is really, it's an appropriate narrowing, I think, of the chemotherapy arms for what you would really do sort of in that setting where you had exhausted prior lines of endocrine therapy. And I think really intelligently too, they were really looking for that initial drop-off. That you used to see on all of the sort of second line endocrine therapies, where you'd have that drop-off, where you'd lose in the first 3 months a significant number of patients. Who were those patients and how are we going to treat them? Because maybe they were not going to be really long-term robust or even, second line or third line endocrine therapy responders. And so they were looking for those patients in DB06 And they found them in the patients who had either progressed on their adjuvant endocrine therapy or who had progressed within less than a year of their first-line metastatic therapy. So we're really looking at a high-risk population here. And then randomized them TDXd to treatment of physician's choice, and again, found a really nice-looking progression-free survival that was really clinically relevant and compelling at 5 months.
Yeah. Boy, we have a lot to unpack here.
We really do. We really do.
So the first thing I want to unpack, from the community perspective.
Yes.
This HER2 low and ultra low.
Yeah.
How is it gonna be? How is it gonna plan out? I can tell you from an academic perspective, we've been meeting so much with our pathology colleague to try to find a way. What are we gonna do with this ultra low? Are we gonna retest all our samples?
Right.
What testing we're gonna use? Because on the study, they used a specific antibody to check for HER2, which clinically there's many different antibodies.
Right.
Should we check that only one because that's one the study? We should check different one. Should we even bother labeling ultra low, or just give it to everybody and look who responds and who doesn't respond, and then change therapy on those who doesn't respond? How do you think from a community oncologist practice, how do you think it's going to pan out, especially this ultra low?
Especially the ultra low. I think it's going to be driven by some practical decisions. I think the idea of using a super highly specialized antibody is not something that a lot of community hospitals or even large hospital networks that serve community settings are necessarily going to adopt, unless that's something that comes out of the ASCO CAP guidelines. I hear that they're revising the ASCO CAP guidelines. So when I asked my pathologist in tumor board the other week, hey, when am I going to get a HER2 ultra low reading on 0+? And she said, when ASCO CAP comes out.
Okay.
And so I don't think it's going to be too terribly long, but I do think that that's probably where in the community we're going to see most of our HER2 ultra low guidance coming from. As it stands now, if I want it, I just call and ask. Yeah. And I'll get it within a couple of few days, and I'll get it faster than I'm going to get a PD-L1 back, probably. Yeah. So it's not that difficult to get, but it is that one extra step. And when you're in the community and, volume is part of your practice, you don't have protected time necessarily, those extra steps really add up. So it's not that somebody doesn't want to go and do them. I mean, every patient is very precious to us, but when it can be, on the original report, significantly easier. And yes, are we going to have to go back and test all of the old samples? Probably most of our community institutions are not going to go back, and I don't see, how they would have be able to do that really, just from a practical standpoint. So we probably will go back to them individually. As you're looking at somebody who you'd like to put on a TDXd, then you'd go back and test them individually, get the result back rather rapidly.
Perfect. And also, if we're gonna look at the community trends or practices right now, is any HER2 low at any point in their history enough, or are we following the most recent biopsy?
I think that any at any point is probably enough. I think that the studies have shown us that at any point, if you catch some HER2, that is going to be sufficient. Even when we were looking, came out of the DB04 data actually, that at any point, if you caught an IHC of 1+ or 2+, even if it was 0 the next time you caught it, this probably has something to do with the variability in reporting. I mean, we know we're using a scale made for an elephant to weigh a mouse. Yes. And that, even amongst pathologists, you're going to have 25% inter-observer reporting differences between an IHC 100%. Of 0 and an IHC of 1+. Yeah, for sure. So there's enough variability there, and just, these are humans trying to use a scale that is not really designed for what they're trying to 100%.
Do. 100%. Because even at large academic centers, there is big discordance, because IHC by itself was never meant to detect what's 0 and what's 1+. It was meant to detect those 3 pluses from the zeros, right? From that they are not. So you're totally right about that. Now, I have a big presence on social media, and one of the things I keep hearing is that it's really not an issue going forward, because you just call the pathologist and tell them, I have a very important therapy. If there is a speck of positivity, then they qualify, and then the pathologists are almost always willing to change the reading to a 1+. Is that something that you see in practice when you communicate with your tumor board, when you talk to your pathologist?
Well, I do think often that when you go to additional levels, if you stain another part of the tumor, that's another thing too. We have heterogeneity in these tumors.
Yes,
Even
for
in
sure.
the HER2 positive tumors, I've definitely sliced a tumor 2 and 3 and 4 times, and I have gotten different levels of positive versus negative. I've had FISH positive, FISH negative, 3+, 2+. So if you get another section of the tumor, I do believe that our pathologists are always aiming to please and also behave ethically
100%.
and responsibly. And I think if they go to another part of the tumor or look at additional levels, they're going to find something different.
Yeah, and I've heard this from a pathologist writing a post on X saying that we don't face the patient. When we understand the situation
Right.
and understand, then, like you said, they do more testing, they try to sort at his heterogeneity, and if it's truly they see like there is some staining, then they change, because it's a biomarker of a therapy and a very
Right.
important therapy, like you mentioned about the data. Now I want to shift gear a little bit to the ASCO.
Oh, sure.
And ASCO 2025, they presented a planned analysis about looking at different mutation landscapes
Right.
that we commonly see in hormone positive. So they looked at 3 things: the ESR1, the PIK3CA, and the BRCA mutation. Can you tell us a little bit about that subgroup analysis or planned analysis, and what did they find?
I thought that was a really clever exploratory analysis. And so you can't draw necessarily statistical conclusions from it, but I do think the numbers that came out of this were really interesting and compelling and led to one big question that I really left that conference with. So going through the data, in the ESR1 mutation pathway, this was around 51% of the, so first of all, they had a set of biomarker evaluable patients. They had done some ctDNA
Yes.
that they'd collected, and they did Guardant testing on it. And then these were initial samples to see who came in with these variety of mutations, and did that affect the results at all. So ESR1 mutation, around 51% of biomarker evaluable patients had ESR1 mutation, and there was benefit. It was about 11 and change months versus around 7 months. And in the PIK3CA pathway, they were looking anywhere along the pathway, AKT, et cetera. That was around 45% of patients came in with a PIK3CA mutation. I think this also goes to highlight the higher risk group that they were pulling out from your patients. And that was also around around 13 versus 8 months, so similar to the intention to treat population. And then and so I started asking myself, it's literally written, before you even asked me the question, it's written in my ASCO notes, am I just gonna be giving in HER2 rather than trying to noodle around with, all of these orals, which are sort of vying for space and attention?
You named it.
Question mark. It
Yes.
has a really big question mark behind it right now, but that was sort of my top line question. And then I thought the BRCA really blew my mind,
Yeah.
I have to say, that you were looking at, so it was only 7% of patients. I think there were about 48 patients total in the group. So very, very small number, whereas the other groups had a couple hundred. And, but in this group, if you had a BRCA mutation and you were treated with T-DXd versus treatment of physician's choice, the difference was astonishing. The hazard ratio was 0.14.
It's impressive.
It was like 21 months versus hardly anything, 7
Yeah.
months. So I went back and I looked back at the Olympiad data to be like, oh, well, was Olympiad this impressive? It wasn't.
Yeah, it was
No, it was
Yeah, I
not.
agree.
It was not that impressive.
Yeah.
It was,
Yeah.
single-digit months.
Yes.
And it didn't have overall survival.
Yes.
Now, we don't know about DB06's overall survival yet. It's immature, so I have to be patient
Yeah.
and wait.
Which is the hard part.
Oh, it's the hard part, because I'm getting used. I'm getting addicted to
Yeah.
having great data coming out all the time.
Yeah.
So waiting, such a
Yes,
challenge.
it's tough. It's tough, right?
It's tough.
But you mentioned it, and you nailed it. And I've heard it so much, even during the presentation, people were posting about why even bother anymore. Let's give a CDK4/6 inhibitor plus whatever endocrine therapy you want, and then we don't even have to check anymore because it works against those with the mutation without. Just go to DDXd. Why are we bothered by doing those extra testing, finding a mutation, give them those expensive drugs that they might work, they might not work, and then sometimes there's co-mutation. What should I do? Should I do that agent as a doublet, or should I do that agent as single agent, or should I just go to DXd? It works regardless,
Yeah.
and it can save our patient and can What do you say to that? Because that challenge for me from the
challenge.
academic side, I want to use endocrine therapy until exhaustion before I go to something like an ADC. How do you feel this dynamic between how community are thinking and how the common practice was before doing endocrine therapy until exhaustion with those data?
I think that it's probably less of an intellectual exercise and more of a patient-centered, practical exercise. Like not only do you want to use, endocrine therapy to exhaustion, but you want to use pills. Patients are going to be so much more, feel friendlier about pills. Oh, I feel okay because I'm just taking a pill. It can't be that bad because I'm just taking a pill. So that's on the one hand, because most of your SERDs and your PIK3CA inhibitors are going to be oral agents. Your olaparib is going to be an oral agent, and so there's some contentment with that. But then on the other hand, a major turbulent disruptor in a patient's life is not so much whether or not they're taking a pill. It's about the time of progression, that moment of progression, that next set of scans. Oh, you looked at them online, you didn't like what you saw, your doctor called you, now you really don't like it, now there's all this upheaval, what are we going to do, how bad is it, is the next line going to work? Like that upheaval during progression is not to be underestimated. And so the longer you can go between those upheavals, that's sort of why I feel as a community physician, there's a lot of value in maximizing progression-free survival and looking at that as a quality of life indicator. And so I do think it also is going to come down to the toxicity of the various agents. Just taking a pill is perhaps not what it used to be.
Yeah.
And so it is important in each individual to be looking at how well they're going to tolerate the nausea of elacestrant, and how well they're going to tolerate the PIK3CA pathway, side effects of a capivasertib.
Yeah.
And is it the right kind of patients that's going to do well? Because we definitely have patients doing well. Or is it going to be the kind of patient that it's going to be susceptible to the hyperglycemia?
Yeah.
And, I would say TDXd is not, without its own challenges. So I do think that you're going to be choosing between the side effect profiles.
Yeah. So let's go into an area where we don't have much data, but that's what I love to do that sometimes, throw some curveballs and see what comes out on the other end.
Yeah.
So I want to do two academic exercises. The first one is, what do you say to those doctors that are currently saying, and there is a few of them, that giving how powerful it is and it gives a depth of response using a drug like T-DXd, why not do an induction phase? So after a CDK4/6, you can induce for a finite number of cycles,
right,
and then go back on a pill as a maintenance, because then you never lose, like cancer never progress on T-DXd or had toxicity from T-DXd. So then you can do those pills. You're not going to lose them, but at least you get a depth of response, eliminated those bad players by giving it, and then you're kind of controlling the indolent disease, and then if the aggressive disease come again, you can then do it again. What do you say to that? Of course, there is no data, but just like, what do you think about that approach?
Well, I think that's something that we're looking at in the HER2 positive space right now. I mean, if you're looking at a patina kind of approach, I think that's exactly a potential direction to go. Would I do it off trial? Maybe not. But would I like to see that come out of the data sometime in the future? I think it would be a really compelling way to look at this, because one of the things that I have heard is, so I'm going to be giving this IV therapy indefinitely. Like, oh, how great that it works, but now we're going to be doing this indefinitely. Well, yes, but you were comparing it to chemo. And yes, one of your chemos was capecitabine, which is pills. But then the other chemos in the comparison arms were taxanes. And, what's your limiting dose? You're limiting it to taxanes. It's either going to be the neuropathy or it's going to be the progressive disease. And neither of those are really desirable endpoints.
Yeah, I agree. We're going to talk about capecitabine, but I want to give you the second curveball.
Yes,
also,
please.
No space of the... So, some people, and because I see a lot of second opinions, is when they do T-DXd, they continue on endocrine therapy. And I'm impressed about the response that I'm seeing. This has never been studied, but some people are doing it. And the crosstalk, I was just talking to Dr. Mouabbi earlier. He was one of those pioneers in this crosstalk between HER2 and ER, him and Dr. Osborne. And it makes perfect sense. What do you say about that?
I say that I was trained by Dr. Osborne and Dr. Mouabbi, and so I have been heavily influenced by years of indoctrination, you know, at the knees of two great, you know, researchers and scientists in this field. And so it has long been my practice, even when it was a bit out of fashion, to go ahead and you know, be using the endocrine therapy concurrently with my HER2-directed therapies. So it's kind of nice to see the data coming around, to see the preclinical and translational data come around, because you know that was one of the other advantages of that group, is how devoted they were to the translational data.
100%. Yeah. All right, so perfect. So we answered two things that we don't have much data about, but that looks promising. So back to the capecitabine issue. So when the DESTINYBreast-04 first came, people were very comfortable with that because they were still giving, if you look at the most common chemotherapy given before TDXd, it was capecitabine. And then on the DB04, the main comparator was eribulin. People did not like eribulin. So they loved the idea of, okay, I'm giving my capecitabine and then I'm going to a drug like T-DXd. And then the DESTINYBreast-06 came. And the main comparator here was capecitabine. You're right, that was capecitabine and taxane, but the main one was taxane. And what you was capecitabine. And then there was a little bit of discomfort in the field about jumping straight to an ADC and not doing capecitabine, because capecitabine is pretty active to a big proportion of our patients. Like I have those patients in my practice where they're still on capecitabine. It's been years since before I even started practicing. Some of them are, and they transition to my care and they're still on that drug and doing well. What do you say to that?
Well, what I say to that is I have always thought of capecitabine as sort of endocrine adjacent. It's an ally.
You definitely got trained by Dr. Osborne. He called it the endocrine therapy on steroids.
Like I said, I've absorbed it. But yes, no, so I've always considered it endocrine adjacent. And so I'd say that, you know, our clinical populations, in my memory, in particular of my clinical populations, is relatively unselected. I too have had patients who've done amazingly well on capecitabine, and they've really had a great quality of life on it, and the hand foot was really minimal, and we've adjusted the doses. I can use it in older patients. Great drug, still clinically very useful. But what I don't know is the backstory on all of those patients. Were these the patients who, you know, on the, you know, in the Emerald trial, if you remember the progression-free survival graph where it just whoop, you know, does it drop off? Are these the patients who were not in that drop-off? Are these the patients who rode the curve, you know, down into survivorship, and then they, you know, they go through their second-line endocrine therapy, and then they're great capecitabine candidates? Or is capecitabine not necessarily my chemotherapy of choice for the patients who just drop off in those first 3 to 6 months, the really primary endocrine resistant patients, you know, the ones with the ones who are 45% PIK3CA mutations, you know, ESR1s, you know, there's a lot of other talk that's happening within these tumors that maybe, you know, the capecitabine can answer to, and maybe it can't necessarily. So do I think that capecitabine is whoosh eliminated? No, I don't. I think it definitely has a place, but perhaps in the category of patients who are going to ride the curve a little bit longer.
Perfect. So yeah, you're right. I mean, to what you said, we always see in all those studies, a third of the patient, I like to call it the waterfall.
Yes.
You know, because it's a drop off, but you know, they drop and then you see the benefit. And you're right, if we can find those, because those patients are essentially endocrine refractory.
Yes.
If you can identify those patients and switch straight to an effective therapy, like an antibody drug conjugate, then that'll be amazing.
And I think that's one of the strengths of the design of the DB06 trial, is that they were deliberately, I think, looking and successfully finding a lot of those patients.
Yeah, because you don't see this the drop off much on the DB06.
That's the first thing I looked for. I looked for that is now what I'm looking for. I'm looking for the drop off.
That's
you don't
amazing.
see it.
I mean,
like
that's
the curves
amazing
separate
insight.
instantly.
That is a fantastic insight. Honestly, thank you. You're right. The DB06 on the TDXd, it did not have that. That's amazing insight. So yeah, so because of that, it makes sense to use it as soon as possible, because you're eliminating those bad clones that we just talked about. But then, devil advocate, it plays here that maybe if you get a depth of response, or you get to what we call the best response, is it time to switch to a less toxic regimen, or maybe at that time do a maintenance capecitabine? What do you think about that?
I think that's entirely possible. I could see doing that because you don't always have a really clear picture of progression. You know, sometimes you have some rising tumor markers, and then you kind of have a mixed picture. And you know, are those lung nodules really new? Were they really old? We practice in Houston. There's a lot going on in people's lungs. Lung nodules come and go.
It's very common.
It's very common. I can't make too much out of them all the time. So if you get one of these mixed pictures, then could you feel more confident saying, well, you know, I think there's a bit of progression, and you know, maybe the tolerance is slipping a little bit. Maybe I can move on to another line of therapy. And because I've got this phenomenal depth of response, you know, maybe my liver lesions have cleared up, maybe my bone disease is no longer symptomatic, then I can feel more confident that I've got some cushion. I've got some resilience built in, that if, you know, I switched to a line of endocrine therapy that I'd not previously used, you know, perhaps based on a biomarker, or if I switched to, you know, an oral chemotherapy, like Payload is the only one, capecitabine is the only one, that I could perhaps maintain that response. And provide a high quality of life. So I can see situations where the picture would not be completely clear, and where I could feel confident about doing that, and then seeing how it went.
Yeah, I want to dig into something else like those ADCs in sequential. But before I go there,
right?
How worried are you in the community about interstitial lung disease? I can tell you from the academic side of the equation, it mobilizes a lot of resources.
Right.
Like, and we're lucky at MD Anderson, we can send them to a pulmonologist.
Right.
We can do those, like, you know, pulmonary function tests and get all those and get them to, but this adds a lot of work. How is ILD being identified, being managed? And it is an obstacle to using TDXd.
You know, I was surprised by this. I had also sort of come up with the idea that, you know, physicians in the community might be intimidated, you know, by the possibility of ILD. And then I was on a call with community physicians who were working in, Houston. I have the pleasure and privilege of working, you know, sort of in one giant practice, essentially, with, you know, how well we know each other, and we've trained together. Like, there's just so much, you know, institutional crosstalk.
Sure.
Whereas if I was, you know, out in other places in the country, I'd be a little more isolated. I would have a smaller pool of resources, and would I potentially be more intimidated by the possibility of a serious, you know, ILD? And the answer is apparently no. Apparently, the community physicians, that at least that I was, you know, on this call with fairly recently, are like, ILD, we can handle it.
Amazing.
You know, because they're not breast specialists. They have really seen a lot of a variety of toxicities. They're using immunotherapy all the time for a variety of diseases, and that is definitely non-toxic. And you're going to get, you know, inflammation in your other diseases. And so they've seen it before.
Yeah.
They're like, I think of them as like the ground troops. They're like, I am not afraid to just run right in there.
And that's exactly what I see. They're not afraid, which is
afraid.
impressive, right?
Oh,
it's
yeah.
impressive. It tells you how much barrier we put in our mind, but they don't actually translate in real practice.
Right.
But it is pretty impressive from what I see. And you're right. I trained in the community setting. The oncologist a lot of time is also the primary care for those patients.
Yes.
So you if they become diabetic, you have to manage the diabetes. You have to manage the blood pressure, because sending them somebody else is going to take months for them to see, and you don't have that leisure. But that's why interesting, because that's what I was scared too. I thought maybe they're going to be less and less of, but it was not. That they really embraced it.
Yeah,
which is amazing to see. All right, so now we're going to move on to something very exciting. So again, this is the era of ADCs. We didn't get one ADC, we got a big bang of ADCs.
Really do.
And they keep on coming.
I know, in the back. Oh my God, there's another one.
They keep on coming.
Right.
So in HER2-low, T-DXd is there, but also trastuzumab govitecan, based on the TROPiCS-02, showed that irrespective of HER2-low status or not, this drug is active, and it also has a survival advantage. And most recently, we got the topotecan, deruxtecan.
Right.
How does this all fit into the practice? Mainly what I'm trying to get to is sequential ADCs. What is your take, being that you came from an academic background, but now you work in the community setting? How does sequential ADCs work for you? And let's take two scenarios as you're talking about. One that's HER2 low and one that's HER2 absolutely negative.
Right.
How do you approach those ADCs?
Oh man, approaching the sequencing of ADCs is absolutely water cooler conversation in every oncology clinic.
Yeah.
I mean, how do you do it? Where are you going to start? How do you switch back and forth? I'd say looking at the data, some of the real world data, there was a whole series of posters at the San Antonio Breast Cancer Symposium about 2 years ago now.
Yep.
And it was a really well designed and thoughtful session. And what I took away from those 5 posters was whichever ADC you give first is going to be more effective. And I should not have been surprised because this is sort of a known truth about chemotherapy as well. So whichever ADC I use first, I should be planning that that's going to be the more effective ADC, and that whatever ADC I'm going to use second, I really need to moderate my promises, my estimates to the patient.
Yeah.
You know, I'm probably not going to give them the off-the-shelf, by-the-book, you know, progression-free survival data, because I'm probably not going to reach that if I'm going to be sequencing ADCs.
Yes.
In terms of choosing ADCs, the TROPiCS-02 trial did have overall survivorship, and that was really lovely, but its progression-free survivorship was a little lackluster. And so if I'm, you know, and I know, and they did go back and look and show that it had, you know, efficacy in the HER2 low categories, and it was a later line of therapy, and cross-trial comparison, you know, should not be done, and yet here we are. And so, but if I'm looking at, you know, a PFS, then I'm probably going to be looking at a trastuzumab deruxtecan in a HER2 low prior to, you know, looking at a sacituzumab. And I'd say that, DB06 is really going to be, you know, turning it around for me. And I'm assuming we're talking about hormone receptor positives.
Yes.
So if we're talking about hormone receptor positives, then that's going to really be turned around for me.
Yeah.
With the DB06, I mean, am I going to just be, you know, starting out with T-DXd in everybody except for the absolute zeros, which is a very small portion of my hormone receptor positive population? I mean, from the community oncologist perspective, ease and simplicity is valuable.
Yes.
Listen, from my perspective, ease and simplicity is
For my
valuable.
perspective too.
If there's a drug that I could use in 90% of my patients, that's helpful to know. Whereas if there's a drug I can use in 20 and a drug I can use in 10 and a drug I can use in 40 and a drug I can use in 10 more, and they're all different drugs, that creates a bigger challenge to try to stay on top of, especially when, you know, you're out there in the community, and I've got the privilege and honor of having really an exclusively breast practice. Well, that's only because maybe I'm not as smart as my community colleagues who can keep up with all of this other data.
So tough.
So
I don't know
impressive.
how they do it. I honestly do not know how they do it.
Yeah, it's really amazing.
My hat off for them. I really don't know how they do it. But your question, should we even bother testing for HER2, given that if you take the low and the ultra low, they're 90% of the hormone positives.
Yeah.
So are we really doing all this testing to discriminate? And I use this word discriminate because it pisses me off. We're trying to discriminate against this 1 out of 10 patient that's not gonna make it. And you're mobilizing so much resources to test and test and test. Why not give it to everybody, including that one patient? Because the DAISY study showed that even in the zeros, that one patient seems to benefit better than the response rate was better than seen with chemotherapy. What do you say to that?
That might be the direction we end up going. I don't know that it's, again, once ASCO comes out with new guidelines, I don't think it's going to be too terribly difficult to discriminate your true zeros versus your 0 pluses, 1 pluses, et cetera. So that I don't know that I'd give it to absolutely everybody. Like that might be the population that I'd carve out for another ADC. And then two, sequencing the ADCs one after the other, I think is going to be another just tremendous challenge. I don't think there's a right answer right now.
Yeah.
I think we're going to be relying on a lot of real world data to look at this question as they all come out, you know, one after the other.
Yeah. So I want to go back to that. So there's two schools of thoughts.
Yeah.
And I like to call it the southern versus the northern, because before when I used to treat the HER2 positive, there was a group that went to TCHP that was the west group, the California group, and the east coast was still doing ACTHP. So now with sequencing ADCs, I want to call the southern versus the northern, because
Gotcha.
the northern, meaning the Dana-Farbers of the world, like to do the sandwich approach. They coin this terminology,
Yeah.
sandwich approach.
Yeah.
Do one ADC,
Yeah.
do something in the middle like a chemotherapy, then do the second ADC. Southern approach like Texas, MD Anderson, and those other places like Moffitt, and like to do back-to-back ADCs. So you do one, and the school of thought is that even though you're right, the second ADC is always worse than the first ADC, yet it's still better than chemotherapy.
Yes.
What school of thought are you from?
I am from the school of thought that ADCs usually outperform chemotherapy, and whatever line you stack them up against each other. You stack them up in the first line, they're going to outperform. You stack them up in the second line, they outperform. You stack them up in the third line, you outperform. So if I'm looking at a third line and I'm looking at an ADC versus a chemo, the ADCs you're usually going to outperform the chemo. So really, until I run out of ADCs, then I am more likely to sequence them. Now, is it going to be nice when I have some different payloads? Yes, that's going to be fantastic. To maybe sandwich some different payloads, because I mean, with an ADC, I am looking at a super efficient chemo delivery system. So would I like to vary up those? Yes, absolutely I would. But before, we were blessed with the bonanza of ADCs, I used to sequence docetaxel and paclitaxel, and then eribulin.
100%. People used to do it all the time.
We used to do it all the time.
Yes, all the time. So that's an important question that we still don't know the answer. Is it a payload problem or is it an antigen problem? Meaning, the response goes because the cell produces less HER2 and T-DXd cannot bind and the payload cannot be internalized, or is the cell becoming resistant to the payload? And we don't have the answer to that yet, because then it matters what we do next, because now with T-DXd is the same payload. Would somebody do T-DXd after T-DXd, or you would rather do trastuzumab govitecan because it has a separate payload, given that they act similarly?
Personally, I'm on the payload train,
Payload train,
right now. Could I jump? Sure, absolutely. With different data, I could actually move up the payload train, but I sort of feel like this is placing a bet in Vegas, for next year's Super Bowl. I don't know yet. I've got an idea.
Yes.
I don't know if it's a winner.
Yes. Now, have you done the sandwich approach at all in your practice?
Oh, with chemo in the middle?
Yes. Like something, because especially with the DB06, now we're trying to use T-DXd up front. So this capecitabine business is not being done. So a lot of people think that, okay, maybe then after I will use capecitabine before I move on to another ADC. Have you faced that challenge yet?
I have not done it with intention, but it is possible that I've had somebody whose tumor characteristics have changed. Perhaps I had some ascites that I could tap, and I could get some markers off of, and they went from slightly HER2 positive to before DB06 negative, and so I put some chemo on them, and they were slightly HER2 positive again, and so I might have done it sort of incidentally, but no, I don't think I've chosen it as an approach yet. It doesn't mean that I won't when the right circumstance comes up.
I want to talk about those 1 out of 10 patients that are HER2 zero. When they become endocrine refractory, now we have 2 ADCs for them. We have trastuzumab govitecan, and we have datopotamab deruxtecan, T-DXd. What would you do in your practice? Which one would you go first to?
Well, this is the one where I have an overall survival difference between the 2 agents.
Okay.
So I have a trastuzumab with some overall survival, and I have a T-DXd without overall survival. So I look forward to the T-DXd data in the ER negative population. That's not the topic of our discussion today. We could be here for another hour. But I do think that I'd probably lean toward the trastuzumab first.
Because of the survival advantage.
Because of the survival advantage.
Okay. And looking into the future, what is still missing? What do you want to still see in the field of the endocrine refractory? What are we missing at this point in time, and how can we improve in the future?
What are we missing in the endocrine refractory? The list is long, my friend. The list is long. We are missing better ways to suppress the endocrine system, and so I was extremely hopeful that the SERDs were going to be a fantastic answer. I've been a little, my enthusiasm has been tempered, by the smaller progression-free survival benefits. So I'm not learning my lesson, and I'm very, hopeful about the SERD-CRN approaches or the CRNs themselves, and I'm hoping that there's, a really good way to a real, blockbuster to block the estrogen receptor and to string out that endocrine therapy with a really effective medicine for as long as possible. And then I think that we're going to need some kind of more sensitive biomarker-based approach to how we choose and sequence these. So I was observing this when I was thinking about the BRCA-positive patients in DB06. And I was thinking to myself, what about the resistance that some people might feel to moving an ADC, up, ahead of a more tolerable medication? And it's that if because a BRCA-positive tumor is an excellent example of a highly chemotherapy-sensitive tumor, particularly to a topo-1 inhibitor. So you're looking at the real difference. If that is a chemotherapy-sensitive tumor, not just an endocrine refractory tumor. We make the assumption all the time that endocrine refractory implies chemosensitive. But does it necessarily?
No.
So we're using all these surrogate markers for endocrine refractoriness, but we don't really have a marker for chemosensitivity. And BRCA shows us what you can do when you have a real marker of chemotherapy sensitivity. You have massive differences in survivorship. And that's the kind of thing that's going to make even the naysayers stand up and say, I'm absolutely going to do this. So I would love to see, and I know people are working on this diligently, a marker of chemotherapy sensitivity.
That'd be fantastic. Along those lines, when the hormone-positive cancers become endocrine refractory, it's not all the clones that are endocrine refractory. There are still indolent clones that are pretty much endocrine sensitive. And when you give a drug like an ADC, you're going to mainly be targeting those aggressive clones. Would you, if patient have depth of response and then you see an indolent disease coming back, not an aggressive disease, would you go back to a hormonal agent, given that they're still ER positive?
Would I add? Would I change? If suddenly I'm seeing an ESR1 clone, gradually increase in its percentage, would I add an agent? I do think that nuanced level of sensitivity is absolutely going to be another direction, something that we can do with tumor testing or perhaps with ctDNA. And I think we've seen, and this is probably out of the scope of today's discussion, but I think we're starting to see the power of what some early detection of ctDNA can do for us.
I agree, because the notion of endocrine refractory, those patients were going to chemo and their lifespan was very short. So we used to think that that's it. Once they become endocrine refractory, labeled endocrine refractory, that means they cannot get endocrine therapies anymore. This is changing by getting better therapies that target those endocrine refractory clones, which doesn't mean that the other clone that's indolent is not still there. So that's why I think this is going to change. We cannot say it's absolutely endocrine refractory. Maybe terminologies in the future might change, that we have a clone that's predominant and taking over. That is refractory. And eliminating that clone can give you a way to go back to an endocrine.
Perhaps we're going to call it endocrine dynamic.
I love it. We coined it here. Today, we coined it here. Endocrine dynamics. Thank you, Dr. Cairo.
My pleasure.
Endocrine dynamics. And I think this is a wonderful place to end it. Remember that, endocrine dynamics. Thank you, Dr. Cairo. This has been great.
It's been awesome. Thank you so much.
To meet you today. And I'm pretty sure we're going to have a lot more of those conducted in the near future.
Yes.
Thank you.
Thank you. My pleasure.